Thank you, Lena. Thank you, Dr. Davis. And I'm going to share my screen and we'll start with the PowerPoints. Can everyone see my screen?
Yep.
Great, thank you. So today our focus is trauma-informed practice. The focus that I will be focusing on is connecting the brain to the body and how trauma impacts our body and our physical wellness. And we're going to look at also how trauma impacts the practitioner. So I work with police officers, firefighters, EMS drivers. I also work with some doctors right now, even psychologists, that we're supporting each other about how vicarious trauma affects our body and our practice. We will be looking at attachment, and I really believe that attachment is fundamental for understanding who's walking into your office. What are the concerns or issues that they have way before the traumas even showed up in their life? We're going to watch a video, a 7-minute video from Dr. Perry on trauma-informed and how it impacts the brain. We'll look at the connections between trauma and illness and what we can do as practitioners to support that trauma. We'll also look at ways we can take care of ourselves, because we will experience when we hear stories. I worked at YRAP with sexual abuse survivors and victims for about 6-7 years. And when you keep hearing the stories of people being assaulted or violated or living in fear, it overall will have an impact on us. So we'll be looking at that. And then I will be reading some emails and some texts from some of people who are brave enough to come and join me and support the concept. And also Helena will be speaking at this time. And then we'll hopefully have a question period. I feel like I'm speaking quickly. An hour and a half is not enough time to even, this is just, I really want to be clear here that if we have this workshop, it's just a flavor of looking at trauma-informed. I teach trauma, it's over 14 weeks, 2 courses. So to condense that in an hour and a half is quite a challenge for me, but we're going to try to do that. Okay. So the first question I always ask myself, well, what is trauma-informed? When do we know that we're having, when do we need to be aware of trauma in someone's life? So we need to realize that the widespread of trauma and the path of recovery. We need to understand the signs and symptoms of trauma. We need to integrate the knowledge of trauma in our practice. That's what you're being provided today. What are some procedures? And how do we avoid re-traumatization? So you'd be surprised, in the early 90s, maybe even late 80s, 90, 92s, we used to ask clients who sexually offended them, we'd take them to court, and then we'd ask them to sit in the room with the offender and say, point to that person. Often that person could be a family member or even a parent. And what we discovered is we're actually re-traumatizing the person. So one of the things that I really need you to hear today for me is that trauma has been defined as any time that you want to fight, flight, or freeze. So I'd like you to just take a few seconds now to ask yourself, has there ever been a time when you just wanted to tell someone where to go? You wanted to run out of the room, or you want to run out of the room, but your body just stays still. You'll often hear people say, well, if you were being sexually attacked, why didn't you run? Why didn't you yell? If I worked with Wellsprings, I'm not sure if you guys are aware of it, is in Oakville, and with patients who have cancer. And a lot of them will say to me, I cannot get to the 2-year appointment. After recovery, I just can't go, Mary. And that is a sign of trauma, that they're so worried that they'll find the news that they might have cancer again. They would rather not go. So these are some ways that trauma affects us. And we need to also reflect on ourselves. How does trauma impact us? Was there ever a thing that you just couldn't attend? Was there a test that you just thought, oh boy, if I bomb this, what's going to happen? What's the trauma that's there? Okay, so when we understand trauma, then we can understand versus react and re-victimize. So this is essential when you have a patient in your room if you are working with someone who has been sexually violated, um, worried about a diagnosis. I'm just trying to make it more medical terms. Surgery, this is another one, surgery. I had a client who became pregnant, and the thought of delivering, she was sexually assaulted till the age of 18, and it was a family member, and she was so worried about delivering her baby that she couldn't fathom the thought that she would have to lie in a bed and people would have to look at her vagina. And the thought of that was so overwhelming for her. In her later months, she wanted to abort the baby because of the fear. That is what trauma looks like. These are just some examples in the medical field. One of the common things I'll say to clients is, well, why don't you go visit your doctor and ask them? And the thought, I'm very surprised how hesitant clients will be to just go visit their doctors. And there's a history there. Culture, it plays an impact, we know that. And sorry, I live in the country and there's an animal on my deck and my dog's not too happy. Please. Is that a deer? Just let it go, just let it go, just let it go. Sorry about that, I apologize. So that's a little bit about trauma. Oh, I can tell my kids to be quiet, but it's harder with the dog. I'm gonna have to excuse myself and send him out. Excuse me, I'm so sorry. Please, please, please. I'm so sorry. I'm so sorry. Okay, so let's shift from trauma-informed care. So what that means is, what does that mean in your practice when you're practicing as a physician? What does it mean for you to understand what the symptoms and how it impacts families when they show up in your office? So there is some trauma-informed concepts that really quickly it's important for you every time someone comes into your office or you meet. And I know if you're working in Emerge, you sometimes only have 5-10 minutes with a client. If you're a walk-in clinic, you have 5-10 minutes. And how do you create that safety? And without safety, you will not have all the story in front of you. So one of the things that is essential is safety, is being transparent. And some physicians or some other practitioners have said to me, well, do we need to tell them the whole truth? It's just going to set them off. We can just give them a little bit of information, and then we can work with that. And when they digest that, pardon me, when they digest that, we'll tell them the whole story. Why do we need to get them to worry when we don't truly know all the facts? We actually know that that activates a part of the brain that makes us more afraid. So peer support, this is nothing you guys don't know, but how do we keep this at the forefront of work that we're doing? Peer support, getting people to connect with their communities, collaborating with different people, other systems is really important. One of the things that my clients will often say to me when I say, well, did you ask your doctor that? No, I didn't feel comfortable to ask that. Just recently, I'm working with a gentleman who has, we all know that COVID has been traumatic for many, many people. And I could do a whole workshop just on the impact of COVID and mental health. But one of them, lots of them will say, you know what, who cares? The people who freeze in trauma just go, the doctor doesn't need to know that. I just need to get my medication and leave. So I had a gentleman show up there and he put him on antidepressants and didn't mention the side effects of suicidal thoughts and also the impact on sexual performance. And now it's showing up in their marriage, and it's actually created more trauma. So it's really important that when you're working with your patients that we encourage them to have a voice and ask those questions. And it's also fair to assume you can't ask a question you don't know about, right? If you don't know what to ask. So this is where we have to teach our clients and patients to really share, be curious, encourage them to have a dialogue with you so that you can understand their trauma more. This is an important one, culture, history, and gender. I think it's been in the media and pretty open about different cultures are more hesitant to feel safe in the medical world. There's actual research to support this. We know East Indian culture right now, they're really working with COVID to encourage them to get their boosters and their shots and all these sort of things, and using their own community to educate. So this is something that's we really needed to be sensitive about. And I'm just thinking of COVID because it's on our list, but I've worked with people who are transitioning genders, and they will talk about how important it was to get a doctor to understand them from their culture. And that's not always possible. We can't be naive about that, but we also need to be sensitive to cultural beliefs and norms and what their priorities are and how do we support that. Okay. So I just like to take us a moment here for, it's really easy to look at trauma from an external, right? But most of us in this room, I'm a big believer that people sitting in this room, well, I don't know if the word was room, but on our computers these days, is we've all experienced trauma. And how do we respond to the trauma will tell us how we work through it. And if we adapt well, if we have secure attachment, and we'll get through that in a little clear in a few minutes. If we have secure trauma, if we have secure attachment, we seem to work through and adapt better. If we have networking systems, support systems, then we do better. So I'd just like to take 10 to 15 seconds to just reflect on a time in your life when you want to fight. And I know us educated people and doctors, and we don't fight. If you talk to my husband, he might have a different opinion. So I'd like you to really just take a moment. When did you want to fight, flight, or freeze? Were you at your, I'm not sure what terminology you guys, but we use the word placement, residencies, I guess is what you guys. Was there a time when you want to avoid a patient coming in? Was there a time when your supervisor or your another doctor's coming? Is there a time you want to fight, flight, or freeze? And I think it's really important that we go inwards and ask ourselves that question. So I'm going to just give you about 10 to 15 seconds to reflect on that. I can't see all of you because when I share my screen, I can only see Lisa, Dr. Davis, Lena, and Elsa. But is anyone willing to share a time when they felt the need to fight, flight, or freeze? We expect our patients to do this all the time, and we really need to touch in ourselves, because if we can't do it, how do we expect someone else to do it? Anybody willing to share? And only do it if it's safe for you. Okay. Can I push you guys a little further to reflect on that? Anybody willing to share?
There's a comment in the chat.
Oh, I can't see the chat.
Oh,
Thank you, whoever mentioned that.
So it was, so I put in the chat as a staff physician, this still gets me. So fight, fright, or fleet is whenever I have to call someone who I would consider a senior consultant or a consultant at a tertiary care center, asking for something. So asking for a transfer of a vulnerable patient or in my advocacy roles.
Excellent. Yeah, Dr. Davis, that's a really great example. A simple, and that's part of your job, and how difficult that can be just to ask for, I need a patient to be shipped over. So even what that does to your body. We know it elevates your blood pressure. We know it impacts your cortisol. We know it impacts your brain. It doesn't mean you can't do it. You'll do it, and you know you'll do it. But if you're aware of your symptoms and that reaction, then you could do the trauma work to see how we can work through that so that those symptoms don't have to be heightened all the time. That's an excellent example. And what I love about that example is lots of people will think trauma is, you know, when I teach this in class, students will say trauma is rape or sexual assault or a car accident, which they all are. But the daily impact of trauma, the small little adaptations that we experience trauma throughout the day can just be as impacting to the brain and the system as one big incident. So I always say the intensity plus duration. So if we have one car accident, I deal with a lot of car accident patients, and we have one car accident, we usually can get over it with some treatment and maybe not even needing treatment, but sometimes 3 to 4 sessions and they're better. But I have some people who are on their 5th car accident. And when I tell them, you know, driving could be safe, they can't even believe that. They can't even leave their home. I have one patient now, she won't even take a bus anymore, not even an Uber, because driving means she's going to die. So I want you to really soak in how a small incidences throughout the day can be traumatic without us even realizing. I'm sure Dr. Davis has the capacity, she has the skills, she has the knowledge, she makes it happen, but her body's feeling that trauma. Thank you for sharing. Anybody else, or is there anything else in the chat box that I'm not seeing? Oh, there's 2 comments. Okay. Anybody else? If Dr. Davis can have the courage to share some of her trauma. Anyone else in the group?
I'll share. So when I was in my 3rd trimester, pregnant, I was doing a rotation in Emerge, and we had a pregnant patient come in with possible COVID. And for me, that was like really activating. I found it hard to kind of push through that.
Yeah. So just the connection, that's a very common response with trauma. When we have connection, it can be, you know, our mothers are sick. It can be our partners. We're both pregnant. If this can happen to this patient, can it happen to me? So Marison, is it? How do you say your name? Sorry.
Yeah, that's right. It's Marison.
Marison, you know, how in that moment, right in front of you was, oh my goodness, this could happen to me, and what's the impact to my baby and myself? And you are all in a profession that, especially if you're in Emerge, you will see trauma all day. And what's the impact to your brain on that? Something to reflect on. Thank you, Marison. That's a very good example of how someone just walks into the hospital. You didn't know that was going to happen that day, and it can be a response of fight, flight, or freeze. Thank you. So here's some of the types of traumas that we look at. We can have acute trauma, which is just one incident, like I mentioned, one car accident, or I've even had clients say to me, well, he just touched me once, or you know, my mom hit me once, it wasn't that big of a deal. We kind of talked about it in the incident. I can't trust my mother anymore, but I kind of get over it because she hasn't hit me again. And that's cute. We have chronic trauma, which it prolongs, like domestic violence, the abuse of control. If anybody's watched the series on Netflix, they did a great job depicting the series called The Maid. And one of the lines in the series says, but he doesn't hit me. And we actually know that the constant trauma of living in a controlling, violating, fearful environment can add huge trauma to the brain and actually change the synapses brain, frontal cortex, and executive functioning and regulation systems over long periods of time. And then we have what's called complex trauma, which is multiple events that build on top of each other. So often you'll hear people say things to me like, why do these incidents all follow me? Like, or why can't my dad just stop drinking? Or I'm just thinking of my week. Oh, I have a gentleman whose daughter won't talk to her. And he says, you know, I've been trying for 12 years. Like I was okay when she didn't talk to me for year 1 and 2, but after about 5 years, I severely got depressed and I have no hope that this relationship will ever be amended. And if I die, this is the relationship I have with my daughter. I don't feel like going to work anymore. I'm ready to sell the business, and I'm just going to go live up north by myself until I die. These were the words I heard last night at 8 o'clock. Okay. So
there's a in the comment box,
Oh.
there's a nice comment that might potentially sort of feeds into that idea of complex trauma in the healthcare system right now. So talking to unvaccinated patients about getting vaccinated because of previous negative interactions with other patients or with other folks around us.
Yeah, I'm seeing it in my therapy world too. I have a client right now who's going to take the school board to court, and her partner have agreed to $500,000 budget, and they don't care. They're taking into court the trauma this is putting on their children. I can't even imagine the trauma this is happening in hospitals and in your doctor's offices. I can't even imagine the impact of COVID for non-vaxxers. How do you speak to them? How do you speak with them and that they have their rights to not be vaxxed? And does that go against your own belief system? And those two clashes of exposure, and it's immense trauma right now with COVID. Listen, I'm almost, please don't quote me on this, but I'm almost believing that we're almost under PTSD as a world nation of how COVID has impacted. I have couples who are divorcing because the husband will not vax and the woman's vaxxed and believes strongly, and she has an aging mother in the house, so she kicked her husband out. I have another couple who have bought, this is quite a privilege, but they bought a second house, and she will live in the other house and he will live with the kids because she does not believe in being vaxxed. And within your own institutions, the last I heard, I statistically don't have this updated, but there was at one point in the news that 28% of medical doctors and nurses are not vaxxed. What does that do to a culture in a medical system? That for sure, if this COVID was 3 months, we may call it chronic trauma, but at this point, with this duration of time, it definitely is become complex trauma. And you are going to have to be really creative and not absorbing this, that it's not personal to you, but you're going to be facing this every day in your work for sure. Yeah, so thank you. That's an important statement. If I add, thank you for that comment. I actually know one client who said to me they're changing doctors because every time they go in, they're talking to them about getting vaxxed. So you can see the impact this is having on people in relationships and safety. So where this stands, and I think this supports the comment, is vicarious trauma. So we know that you will all be impacted by this. So if the worldview on profession is working with individuals who experience trauma, how does that now impact you? You might say, oh, I can shake this off. I was in a merge and this happened, or a car accident, or a pregnancy, just shake it off. I'm a doctor, I should be able to shake it off. I often will say I'm a therapist, this is part of my job, I hear these stories. But over time, unless we do check-ins and get support, we can actually, there is lots of research now that studies people's brains that over time, our brain can start getting impacted by the trauma and we don't understand it. So last night I'm working with a police officer and he's saying, look, overall, I've managed this COVID. He used some words probably I shouldn't use in this presentation, but he was like, you know, it was fine. And yeah, sometimes we've had to break out rallies, but he says, it's starting to take a toll on me that I don't want to go to work anymore. He says, and he'll often say to me, I don't even think it's COVID. I just don't want to go to work anymore. And when I said to him, well, did you feel like this before COVID? He's like, no, I love my job. I love it, but I just don't want to shower. I don't want to go to work. I don't want to have to deal with this. I'm just tired. And that's what vicarious trauma over time shows up at. And he'll often say to me, it came like so quickly, like I just one Wednesday didn't want to wake up anymore. That's what vicarious trauma looks like over a period of time on the impact on our brain. So some would argue, well, why are you adding attachment to trauma? Why would you add attachment? So one is because I'm an attachment therapist, and we now know that the attachment styles we have that we've connected with your parents at very early onset of life, we know will give you the skills and knowledge and security to adapt to situations. So we know that attachment allows for sense of security. We know that attachment systems help us regulate. So if we struggle with regulations, how we cope with trauma will really be determined by our attachment styles and what's been wired in our brain from the very onset of life. We also know that attachment allows us to express ourselves, and attachment allows us to be in tune with ourselves. So for those, if I was your prof, I often, when I teach, will say, I'm going to freeze now and you have to ask 3 questions. And students will say, well, miss, I don't really have a question. And I'll say, well, you're going to have to go to a different part of the brain and find a question, because it actually activates the frontal cortex and so on. And when we're not in tune, we know that it can be connected to our attachment style. It also, attachment allows us to explore. Anybody know people who it's my way or the highway? This is the right way. This is the only way. These are usually impacted by our attachment styles. So when we have a secure attachment, our brain has been wired to say we can explore the world and explore different views and different ways to do things without judgment. So how does this show up in your office? This is, I did a presentation already with a group of residents. And one of the questions they said, well, this was really meaningful. I never thought attachment shows up in my office. Well, if you look at each one of these, how safe does your patient, sorry, you guys use the word patient coming into your office feel safe? I sent someone to go see their doctor the other day because they're having palpitations, and just, let's just make sure your heart's okay, and it's racing all the time and they're having a hard time breathing. So I said, I think you need to go see your doctor at this point. And her emotions were just so irregular. She couldn't even put a sentence together, because her brain was constantly speeding up. And she's had a huge trauma background. So I want to, if people can't express, ask the right questions, communicate with you, or even explore different options, their attachment style will impact what comes into your office or the hospital. So these are the 4 attachment styles that we look at. I just got to give a little shout out to Mary Bowen, who is a University of Toronto professor. And she is one of the founders of attachment, and it's internationally acclaimed. She's done research all over the world. And the greatest thing about attachment theory is it doesn't matter what culture, gender you are, it can be applied. And there's been research all over the world to support this. So secure attachment, I'm just going to go through these really quickly, because I literally do a 3-day workshop just on attachment and how we connect. So first I'd like you to hear attachment styles about what is your attachment styles, and that will tell you how you connect with your patients when they walk in the room. And then I'd like you to ask yourself the next question. So if this is your attachment style and someone comes into the room with a different attachment style, how does that impact your relationship when you're doctor-patient relationship? So secure is, love you, love you, love you. I miss you terribly, mommy, daddy. The research mainly has been done with mommies. So if I'm gender bias here, it's because most of the research has been done with moms, but there is people now picking up research with dads and attachments. So what's happening is that this is secure attachment. You have a safe relationship. Mom can leave the situation. You come back to the room and, hi, mommy, I'm really happy you're here. I felt safe when you were gone. You gave me that sensitivity that I can be able to be around other people, because I had no qualms or worries that you wouldn't come back for me. So children feel comfortable to explore their world. They're flexible. They're able to regulate emotions. If they get upset, they can calm themselves down. They usually can soothe themselves. So What's really interesting about attachment is the attachment you have as a child is the patient that's going to show up in your office. Okay, Dr. Blank, I will try that. Okay, I'll try to see if I can do that. Okay, my diabetes is off the wall here. Let's try to see if we can regulate this. Let's see if, diet, I'll go see a dietitian. These are people that will follow your directions. They'll share with you their emotions. They'll share with you their fears, and they'll work with you to get through it. Then we have avoidant attachment. These are the kids that are born with, you're not here when I want you. I always have to take care of myself. These are the kids you'll hear, yeah, my mom was there, but she was really busy working. My mom was there, but she was sleeping. My dad dropped in. He would pick me up Fridays, Saturdays, but sometimes he wouldn't show up. These are kids that experience parents that I love you, love you, love you. I really do love you, but don't show up when they need them. So the words don't match the action, which gives confusing messages to the brain. These children seem to be more negative. They have a harder time getting connection. These are kids who really test you. They'll test you as a doctor. Are you sure? Send me for another test. I don't believe the MRI. I know the pain I feel. These people really feel rejected and are under a lot of distress, and they can be really rigid. It's really rigid, which makes it really hard for them to be in relationships. So you can see what type of patient this would be coming into your office. These are the resistant attachment. While you do this, I need you desperately, yet you just leave me without warning. I get so angry. These are people who resist. They want to cling to people, but they fail how to maintain the relationship. So does anybody know people who know how to go on a first date? They know how to start a relationship. They'll text you 5 million times a day. Where are you? I needed you. You weren't there for me. Doctor, I called you yesterday and I waited 3 hours and you haven't responded yet. And these are people who will then say, see, you don't care for me, doctor. They get really anxious. And often they'll just withdraw. You'll say, come back next week. I'd like to see this infection. And they don't come back. I'm feeling better. Why should I go back? They also really struggle with relationships. They won't share with you the whole story. I don't know if you've ever had patients and then they tell you, oh yeah, I forgot to tell you that this is my 3rd car accident, or I forgot to tell you that I'm also seeing a doctor at the walk-in clinic and he already did that test for me. These are people that neglect responses. They're not very in tune to their body. They weren't taught to be connected to themselves and relationships around them. They could not trust their parent is going to be there for them. So they resist relationships. Okay. So this is what we call disorganized attachment. And this is where we have to look at where people say they love us, they say they're going to be there for us, but it's really confusing. They hurt us. So this is people who've been sexually abused. These are, I worked with a young boy, this is a true story. His father told me he picked him up on Friday at 4 o'clock. The father ended up in jail. He was a drug dealer, part of some organized crime. And he told him he'd pick him up. And this boy, I'm not even exaggerating, for 7 years, every Friday at 4 o'clock, he stood on his steps of his house and prayed that dad would show up. The amount of damage this did for this child, and we legally couldn't tell him he was in jail because the father, anyways, there was lots of legal issues, and this poor boy, the disorganized attachment, so he couldn't connect with anybody. Then he started hitting his mom, becoming violent towards women. It just went on and on and on. So the description I use with disorganized attachment often is caregivers are scary, doctors are scary, therapists are scary. I can't trust you. If my mom and dad can hurt me, why should I trust you? I've suffered. People who have experienced mental illness, poverty, sexual abuse, long-term trauma will often have disorganized attachment. So if you know this is a patient that's coming into your office and you haven't done an ACEs assessment, then you would be dealing with all the symptoms or the reactions, or even misdiagnose this person, because it's really a trauma response and an attachment response that you're dealing with, more than the behaviors that you're seeing in the body. So I'd like you to reflect on that. Just for a fun note, these attachment styles show up for dating, relationships, marriages. I often will see someone who's disorganized attachment in a marriage and find someone with secure attachment, and the secure attachment is going to save their life, and they're loving and kind and supportive. And then the partner who's secure attachment is now 10, 15 years in the marriage, and they're so tired of the disorganized attachment. They're so tired of him or her not believing where she is, or accusing them of having an affair, or disorganized attachment. You know, she's not sleeping with me, so it's her fault that I went to sleep with someone else. Disorganized attachments often, or even resistant attachment, often ghost people. These are the people, I don't get it. He said he was going to show up and he ghosted me. This is usually due to their attachment style. So just fun fact. When I teach this, I teach attachment with my students. They're always, one gentleman said to me in my class, would it be a bad pickup line if I asked someone what attachment style you have before we start dating? So my response is, you can do that, but I'm not sure how far if you'll get to a second date. All right, so I just want to show this video. I'm a brain geek. I'm a proud brain geek. Neuroscience is where really I'm focusing on the impacts of different parts of the brain. And Dr. Perry, I don't know if you've seen this, but this is focused on educators. So what I would like your brain to hear is that every time he says the word educator, I'd like you to hear the word doctor. And I want you to visualize what the impact of trauma on the brain is when they walk into your office. So unfortunately, I couldn't get it to link, so I'm going to have to put it in a different. Can you guys see?
No, I think you'll have to reshare that.
I'll have to really share. Okay, so let me just skip that and stop. Oh, sorry. Okay, so I'm gonna have to get out, I think, right? I have to stop sharing. We use WebEx at the college, so I'm gonna have to go back. Thank you, whoever gave me that feedback. Can everybody see it?
We can see it now.
Perfect. Thank you, Lisa. Thank you. Oh, excuse me. I showed this to my class the other day, so let's start from the beginning.
Dr. Ventrella, I think the audio is sharing like through your microphone, but not through the actual source. So if you unshare your screen, and when you click share again, there's a little button that says share audio. I think that might fix the problem.
See, you guys are awesome. Stop sharing. And then you're
and when you hit
and say hit, sorry.
It should say share source audio or something like that at the bottom. There's like a little checkbox.
It says,
just before you actually.
It says secure, participate, chat, share screen, pause, stop recording, live transcript, breakout.
Yeah, so share screen. The big, it says in green, and then a little pop-up comes up.
Yeah.
And then at the bottom of that pop-up, there should be a check mark for sharing audio.
You are awesome. I'm so glad you're here today. That's great.
Which it is.
Okay, much better. Thank you.
The reality is it has universal application across the entire spectrum of children, whether you've had no adversity or a lot of adversity. And, they're really teaching people about how the brain processes information, what are the circumstances by which we learn optimally, what are the most effective ways to shape behavior. Things like that are universally applicable, and that's kind of what we do with this model. One of the things that we teach with the neurosequential model is a very simple way to think about this. And it basically is that in order to get to the cortex, to be able to reason with somebody, you first need to be connected with them in some way, relationally connected. And so that's kind of the middle part of the brain. But before you can sort of effectively connect with somebody, there has to be at least a minimal degree of regulation. So a very dysregulated kid who's afraid is not going to be able to successfully be engaged. And if you can't engage them to sort of be with you in this moment, they're certainly not going to be able to cognitively learn anything. So we talk about this sequence of engagement: regulate, relate, and then reason. And one of the things that we see that happens all the time, both with parenting and coaching and teaching, is that all too often we adults try to reason with somebody before they're regulated. And of course, that never really works. I mean, all of us, probably had the experience of somebody, coming up to us when we're sort of frustrated and saying, calm down. And as you well know, that very rarely works. In fact, it usually escalates you, makes you feel even more dysregulated. So the fundamental principle of this neurosequential model is to appreciate that the brain is involved in learning, the neuro part. Sequential is that the processing and development of the brain is sequential. And then really the third part is that you have to adhere, you have to follow the rules. You have to follow the rules of the biological organization of the brain if you're going to be successful in parenting, teaching, coaching. I think one of the most important things that educators need to understand about the brain is the way the brain processes incoming information. And the reason that's so important is that the human brain is basically organized in a hierarchical way. So there's kind of a bottom part of the brain, a middle part, and then the top part. And the top part is an area we call the cortex. And I think most everybody's heard of that. And the cortex is the most uniquely human part of the brain. And all of the networks up in the cortex are the systems that help us learn language. They're responsible for sort of autobiographical memory. They're responsible for the ability to think about the future, to think about the past, and essentially every topic that an educator will teach has to get to systems in the cortex. And so really the job of the educator and the job of the coach and the job of the parent and the job of anybody who wants to sort of change the human part of the brain is to get to the cortex. Now, the dilemma is that when I talk with you, the sound waves are translated into pattern neuronal activity that go into lower parts of the brain. And then they get processed, and then they go to the middle part of the brain, and they get processed, and then they finally get to the top part of the brain. And so you don't automatically teach by having a really good thing in the teacher's cortex that immediately gets into the cortex of the child. And so what you have to do is get through the middle part of the teacher's brain, the lower part of the teacher's brain, out into space, into the lowest part of the student's brain, into the middle part of the student's brain, and then finally up to the cortex. So there's a lot of places where that can go wrong. And the reason educators need to understand a little bit about stress, distress, and trauma is that all of those things will interfere with that process in ways sometimes subtle, but sometimes in really extreme ways. You may have a child who comes into the classroom who's very well regulated. Their stress response system is completely normal. And what that means is when they're sitting and listening in a classroom that's predictable, consistent, the teacher's kind, and their cortex is open for business, which means that the teacher will successfully be able to get through sort of that, that obstacle course to get to the cortex. But if somebody has a history of trauma, the stress response system will be abnormally activated, and that will shut down the cortex so that even if you're a really good teacher, the incoming input, the words and the nonverbal cues and all of the things that you use to teach, they're going to get short-circuited on the way to the cortex, and that child will not learn as much.
So I think what's important for me, the reason why I put that video there, because I know it's not about doctors, the neurosequential model is something you need to consider every time you're working with a patient. If you are working with a patient in your office that has schizophrenia or has trauma or has stress and their cortex is closed off, often people will come out of your office going, what did the doctor say? I don't trust the doctor. I'm not sure. I don't believe it. And how does that impact your relationship with them? So I hope you were able to hear that with whenever they use the word educator or coach or parenting, you are often in the role of creating safety for people. If you have an addict who has just finished last night going on a binge of cocaine and then has an appointment with you at 10 o'clock in the morning the next day, and they're going through cocaine withdrawal, you know their cortex has been shut down. And what are behavior, what responses, how are you supporting that person so that their cortex can be opened up? Any questions, comments, thoughts, reactions after the video? Because when I've done this workshop, people will say, well, we only have 10 minutes with them. And you're right, you have 10 minutes to attach to someone, to bring their cortex, to get them to regulate so that you can reason with them. Any comments, thoughts, reactions? I'm trained in mindfulness therapy, so I can sit in silence for a very long time and I don't feel uncomfortable. So I'm just gonna share an observation. When I'm asking us to reflect inwards, there's silence. So I'm not sure what that means. I'm not sure what that says. I'm not going to assume, but I'd like you to reflect on that. What is stopping you from sharing? What is it stopping you from just asking yourself to speak? And you don't have to, because if it's not safe, it's okay. If you were in my courses, it'd be different, but as a workshop, it's a little different. Safety hasn't been built yet. But I really would just like to take an extra few seconds if anyone would like to share. Once you hear that, you're dealing with people's stress response to trauma in your office. What does that mean for you as a physician when working with someone who's bipolar, an addict, someone who has anxiety disorder, schizophrenia? Any thoughts, feelings, reactions once you heard that video? My students would say, Miss, how did you let them get away with that? We always have to reflect. Okay, so I'd encourage you guys to really look at what that means for you in your practice. If you're in a hospital, if you're in a clinic, if you're opening your own private practice, or you're working part-time in working at a walk-in clinic, really ask yourself, what am I doing in that moment to reduce the stress response? Instead of going into straight reasoning, what am I doing to build relationships and safety? And really quickly doing an assessment of what they're bringing into the clinic or physician-patient relationship. Okay, so I'd really encourage you to do a quick assessment every time that you are meeting with someone. So again, this is just a description. The first thing we need to do is get people to regulate. But depending on their attachment styles and depending on their trauma, They might be walking into your clinic or in the hospital and they're already deregulated. And I want to be clear here, deregulation does not mean swearing or yelling. That's a possibility, but deregulating can also be freezing. And many times with trauma responses, the freezers, the isolators, the introverts get misread that they're calm or they handled it well or they heard the news well. But the truth is their brain is still experiencing trauma. Okay, so I just want to highlight that. It's often I'll say to clients, well, why didn't you tell your doctor that? And they're like, I just couldn't. I just smiled and nodded my head. Well, why didn't you ask your doctor those questions? Oh, he just gave me my prescription and I didn't want to ask any questions. I just left. I have a client who in the past who had schizophrenia would take the prescription and couldn't afford the medication. And I'm like, well, you need to tell your doctor that. And they're like, oh, what? So he finds out that I have no money. These are the constant traumas that get repeated in these people with mental health or physical health issues. So the other piece that I really want to highlight is, let's just jump, is how trauma can impact the stress response, and stress response can show up as physical symptoms in the body. So there is some research, and I don't have clinical research to support this, but when I was at Wellspring, often I used to do mindfulness groups and I could have anywhere from 60 to 80 people in a group. And what I noticed, just informally, I'd say, who here lived a life with lots of stress? And I just observed that I would almost say 80 to 90 people in there. So I want to be clear, this is not a formal research, just as my experience would say I had a really high, a really high stressful job. My marriage is stressful. I'm very stressful with my parents or childhood trauma. Okay. Colitis has been impacted. We know that stress and colitis, so trauma responses can affect all these. Arthritis, MS. My brother has MS and he had a pretty successful business. He sold the business and his symptoms have almost gone to zero. Unless he's stressed, they get activated. His walking is better. He's not using a cane anymore. He's not using a walker. If anything, his wife would probably complain that he's playing too much golf now. And I always say if that's the biggest problem he has, then we're doing okay. Asthma, I can't reference or cite this research, but I remember reading it, it's a few years back, that parents who have stress in their marriages, every time parents would fight, children would activate a response to the brain and would have an asthma attack. And we know that often with domestic violence, addiction in couples, excuse me, pardon me, asthma will get activated. And we know that then the focus becomes on the child and it's a way of de-escalating the trauma in the home. So I'm not sure how many physicians, when a kid comes in with asthma, how many of you guys ask, well, what's happening in the home? What's happening with the couples? What are they seeing? Is there stressful? Or are the kids experiencing stress or trauma? It's something to ask. Crohn's disease, chronic disease, I could go on and on. Stress response. I have a woman who's trying to get pregnant, who's now on her third or fourth attempt in vitro, and she just recently lost her last attempt, and the stress hormones are just she's saying, Mary, I can't control myself. And this woman has never had deregulating issues previously to trying to get pregnant, and the amount of stress that it's adding on her marriage and now her in-laws, it's just spiraling all over the place. And really the response is she's pretty hurt and grieving. The response of losing, in her mind, she refers to it as her child again, and she's tired of losing her children. So you can see how stress and constant and chronic and experiencing trauma over and over again can have huge impact on physical wellness. And how many of us are asking when they walk in the room, how much trauma are you feeling? And you'll hear some examples from some people who are brave enough to share their story that will join us today. So characteristics that bring on disease that we know that when we're doing assessments, when we're looking, we need to look at the trauma like we've been focusing, but there's also Isolation. So we often will look at behaviors, but we don't look at the quiet ones. So often I'll say things like, yes, Johnny in the house is the addict and brings torment to the family, but the sister's upstairs with an eating disorder and cutting her wrists, and no one even attends to that. And I'll often say to families, can I see your daughter? And they'll say, oh no, she's fine. She's a straight A student. She's doing really well. She's got a nice boyfriend. We really like him. She goes out on weekends. We have no problems with her. And I said, well, you know, I'd like to visit her just to get to know her a little better. And then she comes in my office and I find out she's a cutter and she's also using drugs on a regular basis and she's thinking of suicide. And parents and families have no idea that this is happening. So isolation is something we really need to look at. We mentioned stress. One of the things that's a common characteristics is we ignore our own needs. So, you know, those pleasers, don't worry about me, take care of my child. Don't worry about me, take care of my mother. Don't worry about me, I'll be okay, I can deal with this. We know over a long period of time that that can impact the cortisol in the brain, the cortex, the regulating system, which then can also increase the chances of disease. One of the things that we need to look at when we're working with patients and asking is about their life balance. If I'm going to be really honest, I'm pretty good with life balance, but I think at this point with my COVID, I'm surprised how much energy it's taking out of me and how difficult not being able to breathe and taking deep breaths has impacted me, which has impacted my exercising, which has impacted my dopamine and serotonin, and goes on. And you all know that once you get into that rut, how hard it is to go back to exercising. So that's something really we need to look at is the life circle. Often I'll ask patients, just even on a first day, I'll say, can you just give me a circle and give me where you spend most of your time in your day and give it to me in a pie so I can visually see it. And if it's balanced, great. And if it's not, then maybe we need to look at where we need to rebalance. So that's something you can do in your office really quickly. One of the things we know with trauma and resistant attachment is we're not very good at expressing what we need. We're not good at even identifying anger or hurt or pain. So I always say anger is a secondary emotion. Many people will get angry, but it's easy to show us. But the real truth is they've been hurt or there's pain there. And how many of us address the emotional pain? And listen, the truth is, as a doctor, you don't always have time to do that. So what are you doing to refer out to someone so that they can look at their pain so that which will impact their physical well-being? The other thing is you're responsible of other people's thoughts and reactions. This is a characteristic that people will often say, well, I'm not angry, they made me angry. You know, my mother's been like this my whole life. You know, so I'll just accept it. It's fine if she wants to, you know, say those things in front of our families, you know, over the holidays. And I'm saying, no, it's not okay. Because over time, that creates trauma for you that you just want to avoid eventually, or you'll get to a point where you get really, really resentful, which one then will create more trauma. So I always say we have three brains. We have our neural brain, you know, our frontal cortex and our amygdalas and all those parts of the brains. We also have a heart brain, and we also have what we call the gut brain. And I think we give lots of attention to our head brain. So when your patient comes in your office, you hear their head brain and their symptoms and their all those sort of things. But how many of us ask about their emotional well-being? And gut brain to me is intuition. And I'm not sure if you're aware, but CAMH is doing some really amazing research right now with bipolar clients. And we're discovering that gut does communicate with our neural brain, and food and plaque in our gut. We have actually, the research is showing that less plaque in the gut sends different messages to the brain, that people are able to regulate their moods and not have extremes, highs and lows with bipolar patients. So this is pretty exciting. But how many of us ask our patients that? Are you paying attention to your intuition? If you're interested in this a little bit more, there is a doctor in California, Orloff, and both of her parents, I think one was a psychiatrist and one was a brain surgeon. And the doctor, their daughter said, nope, I'm going to focus on intuition. and they were devastated that she was not going to become a surgeon. And she is a medical doctor, but also trained in psychiatry. And her focus really is about exploring the intuition and disease. And it's really exciting about that. How do we reduce these symptoms? As doctors, this is one of the things we want to really emphasize. How do we reduce symptoms of stress and trauma? We need to build on our clients' strengths. We need to teach them to ask for help, take time for themselves and take care of themselves. Often I'll use the words, what's your authentic self? So the school board wants you to do this. You feel guilty, you're going to be sick for the kids and they've been through enough. But what's your authentic self need? How are you expressing yourself? Reaching out to friends and families. And if you can't, professional support. And I'm always, I don't know why I don't have exercise in here. Every client I meet with, I say, you got to move your body and we got to find a place to regulate your brain and either pray, be mindful, sit in silence, go for walks with no agendas, but really be present so that you can start listening from your gut and your heart also, not just your head. Okay, so one of the things that we can do in a doctor's office is we can do what we call adverse childhood experience assessments, and it can be done really quick. You can download this, and you know, I used to in my early days click each box, but right now I can basically sum it up in a few sentences. And really looking at ACEs is really looking at the traumatic events that have happened in the childhood. Has there been abuse or growing up, mental health, substance abuse? Don't be surprised. People who have substance abuse will define substance abuse very differently than the medical model or the addiction model. No, I just drink, every once in a while. And I'll say, well, then how much do you drink? And they'll say, well, 3 or 4 glasses a day. We're heading to some concerns there. Since marijuana has become legal, this is a huge impact on the brain. I'm not an addict. I just like smoking pot. I'm not an addict. I can quit whenever I want. It's legal now. It's not a big deal. These are things that we have to jump in and ask secondary questions to understand how often they're using, how much it impacts them. And the other thing is vaping now is a huge one. And we know that vaping also has huge impact on the brain and the regulating system. And kids just think, well, it's not a big deal. I just do it on my friends. And after school, we're hanging out by the buses before we hop on the bus. Well, what's the impact of that? ACEs is also looking at the toxic stress and the duration and intensity. So if you have someone who walks in your office that says, yes, I was sexually abused, but I've moved on and I have a very successful life, we can look at just doing a quick assessment about how much that impacts on their physical, mental, and emotional well-being. Okay, I'm just looking at the time, so I think I added way too many slides, but we're gonna give time to Halima for sure. Okay, trauma factors to consider. These just really quickly, this is, if you don't have time to do an ACEs, really looking at childhood, work, marriage, biosocial, and environment. One of the things COVID's really impacting people is the biosocial. Even the introverts are saying this is too long. I've been home. I have a client now that's been home for 2 years. She says she has a desk in a cubicle in a corner. She refuses to go to school because she has anxiety. She doesn't love the online learning, but she says the only relationship she's really spoken to is her mother, her sister, and she calls it the 2 walls. Now she has developed, she says, my relationship was with the 2 corner walls. That's the extent of communicating with others. Over periods of time, she's become very, very depressed. She hasn't even been able to shower. I have another client who is a very successful woman. Her budget is probably $1 billion as in her position as a CEO. COVID has impacted her so drastically that she wasn't able to shower up to 18 days. She says she uses dry shampoo, she sprays it in her hair, she does her meetings in her mornings, and then she goes right back to bed. She's doing bare minimum. And the last few months, she's been saying to me, Mary, if we go back to work and I have to take the GO train, my brain just can't do it anymore. I'm going to quit my job. This will have significant impact on her relationship and her children. And this is how much biosocial and COVID has impacted traumatic events in people's lives and the ripple effect of that. Okay, so she maybe didn't have childhood trauma, But with COVID and the duration of time and the intensity of it, it's getting to the point where it's affecting her socialization and her environment and her family. Okay, so we know that with stress and trauma, the short terms, our heartbeats, we want to fight, flight, or freeze, our cortisol gets unbalanced, regulation systems take harder work to balance that all out. You guys, I don't have to convince, this has great impact on the body. Long term, it starts to affect our immune systems, our heart disease, asthma, arthritis. Even there's some research that talks about thinning of the bones. Oh, I need to correct that. Okay, here's just some quick stats and some percentages of how it affects conditions of stress. We know, I think the last I heard is divorce with COVID has increased by, now we're at 58%. No, domestic violence is 58%. Divorce has gone up 54%, something like that. So don't quote me on that. It's not, so think of the impact that has if domestic violence is going up. Listen, couples were not meant to be a year. Most of us spend a week away, if that, and have an evening, and then we go back to work, and then we meet the next day. So the intensity couples are experiencing is really increased divorce during COVID. I'm not going to go through each one of these. The other thing COVID has had a huge impact is the social economic status of people. Many people have lost their jobs. People are worried. Some people have made money, but some people have also really suffered financially. So this is just something to think about. We know that, there's some jokes going around that everyone's put on anywhere from 15 to 19 pounds during COVID. Well, what does that mean for our people with diabetes? What does that mean for people with physical knee problems? What does that mean for people who are already obese? What does that mean for heart disease? So you can see all these are all interconnected. Okay, before we go to questions, so I took some questions from my last presentation and I just added them in here to make sure if you guys had any questions there. But before we bring in some of our guests, I did ask about 4 people to come and join us and share their story of trauma and how it's impacted their emotional and physical life. One was really gung-ho, and this morning she froze and said, I just can't do it. I'm sorry, I'm just gonna stop sharing now. She just said, I just can't do it. I'm so scared. And I talked to her this morning about 7:30 and I said, what is your fear about? And she says, they're doctors. And I said, so if they were someone else, would you fear this? And she says, no, there's something about that they're doctors. And at first I thought, well, okay, they're not your doctor, but so she just said, no, I just can't do it. I just can't do it. So she gave me a write-up, and I would like to start with that. But before we shift to hearing their stories, because they are the real teachers. This is theory, this is important, this is some experiences, but hearing the stories of what people go through with trauma, and when we're not trauma or practicing trauma-informed practices, we can actually do harm. I want to emphasize that again. If we are not practicing trauma-informed practices, we can do additional harm and increase the trauma response. You and I know society see doctors as a safe place. They're supposed to have my back. They're supposed to advocate for me. You and I know there's restrictions with all that, but we really need to take responsibility so that we don't increase the symptoms of trauma. So before we start that, I really would encourage you to ask any questions and really look at yourself and some of your responses of things you've heard, even disagreeing, I'm okay with that, or challenges. The floor is open and the floor is yours. Any questions, comments, reactions, thoughts? Sensations in the body, I often ask, because people who have been through trauma disassociate from sensations in the body. So I'll often ask that too. Questions, comments?
Dr. Ventrella, thank you for your presentation. I just had a quick question about just looking, like thinking about future practices. I know it's realistically, family doctors usually have like very short 10-minute, 15-minute interview, and a lot of times patients come presenting with something else, but they actually have other issues, that more chronic issues that they want to discuss or explore. But I think, sometimes the difficulty is bringing them back to, with a bigger time slot, so that we can really explore this further, but kind of building a quick report in that first visit so that it encourages them to come back and talk about it. Like, is there any things that phrases that we could say or things that we can do quickly in that 2 to 3 minutes?
You guys are like superheroes that have to fly in and fly out real fast. I get it. I get the privilege of being with someone for an hour, so definitely there's a difference, or even an hour and a half. So Lisa, can I call you Lisa? Is that okay? Lisa, one of the things that I often will say to clients when they go to the doctor, so I have lots of rapports with doctors, right? So I'll just use Dr. George, I call him, and I'll say to Dr. George, often tell them, don't worry about it. If you didn't show up, come when you're ready. I won't judge you. I have clients who come, they share their story, they're so overwhelmed by their story, and then they disappear. So I always say to clients, when you walk through my door, you are always welcomed. I will never question. So everybody, I worked in group homes and I've worked in jails, I've worked with kids on the streets. If you've ever run away from home, not that we were all stable and we don't do those sort of things, but maybe some of us have. When kids used to run away from the group home, they used to say, it was so hard to walk back into the door. Anybody not phone a friend over the holidays, or you should have phoned your sister, or you knew that aunt that you didn't connect with? If you knew that they would accept your call and welcome you back, we won't hesitate. So Lisa, 2 things. Consider resistant attachment. That's just resistant attachment, right? And I always tell my clients, I had a young girl yesterday, she says, this was before Christmas, she says, I was so scared to come back to you. She goes, I thought you would be angry that I missed 2 appointments. And I said, angry? I said, what? I said, come on, give me a hug, get in here, let's start. You're always welcomed. The word welcome to the brain is really, really powerful. My students will often say, Miss, today you forgot to welcome us. And I'm like, all right, welcome to class. So it sounds like a simple intervention, but it allows permission to go back without judgment. Great question, Lisa. Great question.
We do also have a couple questions on the chat.
Oh, great. I could open it.
Thank you for the presentation. I'm wondering if you can suggest some practical tips to incorporate trauma-informed care when we see patients. I understand we have to be aware that people may have experienced trauma, but what can we do universally?
Yeah, that's a hard question, but I'll try. So the research shows when you're regulated and you're truly present, we actually know our synapses brains can match each other. Kids, adults, we can fool. Kids are way smarter than all of us. No disrespect to anyone. Kids know when you're not truly present. So you truly have to be checking in with yourself, is what I would say to that, Nicole. And when you're walking into that patient, are you truly present? It's you and that person. And connection. Now, I know there's all these rules about touch and all those things, but we actually know even a simple touch on the shoulder, a simple touch on the hand, a simple feeling safe, as long as you have their permission, always ask permission. But it's really important for you to explore your own attachment skills, that when you get a client, you have 11 seconds to connect to that brain, that they will feel safe with you. So relationship. If you're coming into a patient and you're thinking about 3 patients that are just come in because of a car accident, you're truly not present. People will feel that. So genuinely be in relationship with that person. Often I'll even say, I'm just going to take a deep breath so that I can be in this moment with you. I literally have 2 minutes with you, but I'm going to take a deep breath so that I can truly hear you. And often I'll say an intervention I'll use is, what's the one thing you want me to hear before I walk away from you? I want you to hear that I was really scared to come into session today. I heard that. The intervention, I see you and I hear you. Such powerful words for that person to say, I was seen and I was heard. Many people with trauma will often say to me, I was not seen and I was not heard. Okay, hope I answered that question. Do you have any advice on how to help patients regulate when they're having heightened emotional response? You guys don't ask easy questions. This is good. I like this. Did I miss a question? No, I think I did. Thank you. Okay, no, I didn't. So that regulation is a challenging one. Some people, I'll often say, let's just breathe. We know breathing regulates the system. We don't have time, but I could do a whole piece on regulating in the brain. So all the balls are in the air, the neurons are in the air. I often will say, if all these thoughts are going in your head, your heart's feeling all these things, what's the one thing you want to stay in an I statement? I need you to hear that my mother's an effing beep. Okay, got it. Is that what we're focusing on today? We're going to just focus on that. So it's your job to regulate yourself, Madeline, and then regulate. That will help them regulate. So the worst thing we can do is say, hurry up, you know, I have 10 more minutes. I have 3 more patients outside in the hallway. That will actually regulate them more. Don't problem solve. So I don't know if you heard Dr. Perry say, don't reason with them. Like, you calm down, you're safe here. Don't worry about it. I hear you. We'll get through this. Those statements do not help. And Madeline, because of time, I could spend a day just on that. Regulating system is probably 80–90% of the work that I do now. I'm trained in EMDR and brain spotting. I do a lot of regulation with neural systems. I cannot believe how much it's changed the work that I do. So I hope that's just a quick feeling of some of the stuff. Nikki, thanks for your presentation. I think it's important to integrate the idea of work-life balance in the work. Oh, Nikki, I'm just going to say amen to that. There are really powerful structural sources, heightened burdens on some. One that comes to mind is the burden of domestic and paid work combined that falls to a great extent on women. I think when we speak to patients about work-life balance, we need to prioritize this. Nikki, I couldn't have written that any better. I think gender, I think family structures and families are changing. I think there's more single parents, there's more blended families. We really need to look at work-life balances. And we also need to look at systemic balance. So we can say this all we want, but if the systems around us are not supporting us, we could still have some systemic trauma and abuse and oppression. So, you know, I have some judgments about the model of, you know, doing 12-hour shifts. You know, at what point is your brain shutting down? At 3 in the morning, we know the frontal cortex is not being able to regulate. And you're an emergency doctor who has 2 car accidents that come in on Christmas Eve. You're away from your family. And I know that's part of the job, but what impact to your brain? And where are your support systems and as medical doctors to have debriefs and supports and encourage the change in the system? So I've worked in group homes and we've been I've been physically hurt. We've had staff who have been stabbed. I had a staff who smashed a guitar over his head at the jail and the guitar was stuck on the staff's head. And the trauma with that, and we had 6 or 7 inmates running around. What did the system do to support us? So work-life balance, I cannot emphasize that enough. Am I great at it? I'm not great at it, Nikki. I'm working on it. But I did do one thing. I was told to write another chapter. I'm writing a book on trauma. And I said no this Christmas holiday, and I've never done that before. So I'm getting a little better, Nikki. So please stay attention. But you also brought up a really powerful statement there about women and our roles and our cultures and how they're shifting. That is significant, but also families are shifting. We have more blended families now than traditional families. What does that mean? How do we balance all of that? I think I've addressed, for another example that comes to mind is the healthcare system that residents work in are impacted by policies, the goal work-life balance. Yeah. Nikki, I will say this. I have lots of professionals on my caseload that I'm doing EMDR. Teachers right now talk about trauma and systems. Teachers, principals, doctors, firefighters, domestic violence, police officers. People are going into homes right now and finding partners who are dead. this has great implications on work-life balance. And then you have to go home and be a dad and be loving and be a partner and go to the zoo and make love and buy Christmas gifts and celebrate Hanukkah. And how difficult is that? Okay. If it's okay with the group, I'd like to turn it over to Halima. But Halima, before we start, I'm just going to read. Miss T sent me a write-up, the one that today could not come in. It was just traumatic for her. And she says, "I'm sorry, and I'm afraid that I can't make it today. Early this morning for me was too overwhelming, and I was recording in my morning pages to try to regulate, but I just couldn't do it. It was too scary. So I sincerely apologize to all those that made it to the presentation. But in a sentence, as I just wrote in today's morning pages, trauma has impacted every cell of my body, and being to an extent nobody can ever understand, not even myself, as it's a mind-numbing complex, and there's no such thing as a physical health standing alone. Even though we talk all about it, we talk about my trauma, but living it is a very different story. For me, the miracle hasn't been the healing, it's been the awareness, because the same can't be said for my siblings. My siblings continue to live in numbness and refuse to talk about the abuse we experienced as in our childhood. However, it doesn't feel like a miracle. It feels like a punishment, which fuels the self-punishment, the system already in play as a result of interrupted and uninterested behaviors of my parents as personal failures. The current miracle is that I have learned to ask for what has seemed authentic. It feels overwhelming, and some days I get so scared I can't roll out of bed. For help for my life, as I had to do everything alone from the age of 3. For healing for me, it began to free me. Without working on this, I would have been a prisoner in my own body. And asking for it now, I have spent many times my whole life trying to get grounded to unconditional love, purpose, connection, what other people naturally do so easily, has been a life of torture and continuous work for me. If that doesn't explain how trauma impacts us and our physical well-being, I don't know what will. Halima, I want to honor you, respect you. I'm so proud of you. The floor is yours, and you share what your truth is. And please be kind to yourself, be gentle, and honor yourself in this process.
Thank you, Mary. Hi, everyone. My name is Halima Faisal, and I'm a first-year university student studying the medical sciences program at Western University. So I wanted to talk about my experience regarding how the state of my family's mental health has impacted my own psychological and physiological well-being. So growing up, my parents did not have a very healthy marriage due to the clash in their backgrounds and their childhood trauma. And this really did project onto me and my older brother. My brother protected me from getting caught in their mess until this previous summer when he was diagnosed with schizophrenia after his second psychosis episode, which was set off by substance misuse. So seeing his lifestyle now is a perfect illustration of how our physical well-being depends essentially on our psychological state. He not only has gained a considerable amount of weight, but his facial features make him look severely unwell. There was an indication of schizophrenia prior to the diagnosis based on his lifestyle and his inconsistent appearance, but the specialists neglected his psychological state and considered it as a lack of ability to concentrate, prescribing him ADHD medication for 2 years. So the doctors had treated my brother for 2 years after his first psychosis episode in 2019. But what happened to the rest of the family in those 2 years? The stress prompted my father to fall further into alcoholism and eventually leave the family. And my mother's internal organs further deteriorated due to the pressure that comes with the involvement as a single mother with a schizophrenic son. And overall, my unstable mental fitness was affected. The feeling of being powerless over this home environment where everyone's physical health mirrors their mental state had begun my battles with an active eating disorder, leading to inconsistent hair loss, skin breakouts, and weight gain. My family's physical health was a direct indication and a symptom of our deteriorating mental well-being as a system in the course of the recent years. And my mother has spent countless hours researching how to get my brother back on his medication in order to proceed with his life. But the mental health department in Canada has left us feeling neglected and hopeless. It's frustrating to have to see what the ramifications are of disregarding the root of the issue. And it's even worse to not be able to do anything about it. If my parents' childhood trauma had been healed and treated, I could have had a much different reality in which my brother could have been helped, and we could have avoided many other traumatic occurrences. The relationship between mental and physical well-being is a vicious cycle that will be repeated if the core of the issue isn't fixed. The problem isn't that there aren't enough resources to help solve these issues, it's that there isn't sufficient focus on it. We need to make a change with how much attention and time is allocated for our mental health to prevent other families and individuals from suffering. I hope sharing my story today will help everyone understand why it's so important to shine a light on the rising mental health epidemic and why we should educate and focus more on this relationship. Thank you.
Halima, if I could stand up, I'd give you a standing ovation. I am so proud of you. I know how much courage that takes. Yes, keep the thank yous going. Halima, your story really inspires me, and your bravery, and you really depicted systemically how trauma impacts everybody. And this is a loving, supportive, encouraging, beautiful family. They really, really are. I've had the privilege of knowing them. Thank you, Halima. I'm so proud of you. Halima will become a psychiatrist one day, so she'll be working with you guys one day. I have no doubt in my mind, Halima. You're awesome. Thank you. I know how you're so brave, sweetheart. Actually, I'd like her to become a psychiatrist so I can refer you my clients instead of having to wait. Do you know that people are waiting up to 2 years now to get an appointment with a psychiatrist? That's crazy. I want to just I'll share one other story because I honored my client, Irma. She got into a severe car accident, broke her back in multiple places. You all know where this is going. She's now on Percocets. She can't live without Percocets. It's affected her marriage. It's affected, thank you for sharing, Halima. You will be, oh, that's great feedback. Did you hear what Halima, you'll be a great psychiatrist. Yes, she will, I agree. So Irma would say to me, Mary, the trauma of this car accident changed my whole life. She was a career corporate woman, an international businesswoman, and now she can't walk to the bathroom. So I just want you to think about what that trauma has done to her. But I'd like to leave on my last story because I met with her yesterday and I'm so excited. Miss Paula has tried 3 in vitros, has not been able to get pregnant, and the doctors could not find anything physically wrong with her or her partner. The science was all good to be able to get pregnancy. No one ever asked her about her trauma, and the doctor that's in your residency referred her to me to do EMDR with her, and I discovered she had a memory that she was severely raped by multiple people when she went for an internship in Africa. This was a family acquaintance, so she couldn't disclose it. She hasn't slept well in years. We now, with EMDR and brain spotting and counseling that I've been working with her, she's been able to sleep up to 4 to 5 hours. It's changed her life. This is an exceptional case. I have to lie a little bit because I hope none of you know her, but she got an egg donor. She's inserting it in, she inserted it, and she's now 28 weeks pregnant. She's never been able to hold an embryo in her body for more than 2 weeks. She is ecstatic. We do weekly 2 hours EMDR sessions, even if she says, I'm doing really well, Mary. I don't think I need it, but I'm coming to you. The doctors are saying, or whatever you're doing, just keep on doing it. And she really believes it's attending to her trauma and attending to, and doing the EMDR. EMDR works with the neural sequential brain and those pathways from trauma in her brain. How great is that? How is this going to change this woman's life? so we're at 28 weeks. How long, you guys are the doctors, how long does she get at it? Like how early can a baby be born? Because we check X's all the time. When a baby's safely born, what is brain spotting? Oh, that's a good question. That's a whole other workshop. So I have some private messages. Can I read them really quickly? Hi, do you think it would be more turn on? Do you think it would be? Yeah, I would like cameras on. I like seeing people's eyes, and yes, I agree with you. Thank you, cameras. If I was your prof, I'm not as nice as some teachers. I'm like, put your cameras on. And I don't care if you're having a sandwich or you're playing with your dogs or breastfeeding. I have students breastfeed. I have a newborn baby that's come to class. I have babies who say to me every week in class, hi, miss. What is brain spotting? So brain spotting, EMDR was first developed. I'm just worried about the time. EMDR was first developed by and it's looking at by eye movements. We can activate different parts of the brain. It's I know this is kind of geeky, but once Oprah picked it up and Prince Henry went publicly on Oprah saying, I did brain spotting with my trauma with my mom, the whole world kind of went on it, but we've been doing it for years and years. Brain spotting is actually moving along the spectrum and looking at the eye contact and looking at where it activates in the brain. We can actually activate trauma. But I'm also trained in sports and creativity, that I'm working with authors and actors, and I'm doing some really great activation and getting the frontal cortex. So on a really simple, 3-hour workshop that I'm doing in 3 seconds, this is our brain. Brain spotting activates this part of the brain. We know that through eyes now, there's nothing that activates this part of the brain. So you ever hear people say, I've been sexually abused and I have no memory of it? Or all of a sudden I'm driving down the street and I'm flooded with trauma. What the heck was that all about? Or I keep meeting the same type of men, or I keep meeting the women who are narcissists. We know that if we activate that part of the brain, we know there's some trauma there. And we can do that through brain spotting. So, and what's really amazing, it's an expensive training. And I know you guys are students and if you're in student loans, I get it. I'm a coordinator, all that stuff you have to think about. But often in Europe, when I'm doing my trainings, most doctors in Europe, New Zealand, even Israel medical systems are using EMDR and brain spotting. That's part of the requirement to be trained. Isn't that exciting? It's so.
Sorry.
Yes.
We just have a quick question that was missed last time.
Oh, thank you, Lisa. Can you remind me? I'm sorry.
Yeah, Atiba asked, speaking of checking in with ourselves before we attend to an individual patient, any strategies for disclosing to preceptors or even to patients that a situation is causing us trauma? Should we step away, or we're always taught to pull through?
Yeah, that's a really, really good question. My students ask that often. So I always say, share only as much as it's going to serve the client or patient. So let's say I'm working with Halima or someone, I don't know, Jaspreet, and I will say to them, I have 3 boys. Now, do they know that yesterday my son drove me crazy and I yelled at him because he's on Discord versus his science class? No, they don't need to know that. Halima, you don't need to know that. So I always say share only as much as it's going to meet the need of the patient. So we have to be careful with things like, oh, I too was sexually abused. Oh, I too am going through divorce. I too am, I know what it's like to be a single parent child. If it's going to serve, so I will often say to clients things like, yeah, as a mom, that's hard. Like I've had times when I've wanted to yell at my kids, but I won't go through the specifics of it. Or, when I'm doing marriage counseling, they're like, how would you understand? You're a therapist, you must have a perfect marriage. And I'm like, have you lived in my house for half an hour? Come in my house. You want to talk to my husband? Maybe you'll get a different idea. But I'm not telling them things like, this is not true in my life, but I'm not telling them that my partner's having an affair. I'm not telling them that I was suicidal at 16. Now, I do have some clients that I've worked with for a long, long time. And I'll say, hey, Mikilina, don't think it's always perfect over here. I do say things like that. And I've had clients say that the client T will say, You know, Mary, I've seen many, many therapists, and I'm so sick of them taking notes about me and not giving them a little piece of yourself. So do I wish them happy holidays? Do I care for them? I have a little girl who mother says, my daughter is driving me crazy. It's her birthday. And all she keeps saying is, Mary hasn't even texted me for my birthday. So she mother texts me, I text her, and I can hear her running down the stairs going, Mom, Mary, text me, it's happy birthday. It's about the relationship. So a quick answer to that is only share what is going to serve your client and not deregulate you. That's an important feature. So if I'm going to share with you, me and my husband are getting divorced and I'm going to start crying, then it's not the right time for me to share. When my father died, I had to go do my own EMDR work because a client said the word dad and I started crying in session. I said, I gotta go do my own work. Now I can say the word dad, miss my dad. I love my dad. I wish he was here, but with a smile on my face because I did my own work. So I'm not here to say everybody needs to be in therapy, but we need to have a system that we reflect all the time. So I have my own therapist, I have my own consulting team, I have friends, colleagues who I can call and go, you know that Halima girl, she drives me crazy, blah, 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 blah. It's not true, by the way, but she blah, 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 blah. Then I can go back and go, I really care for Halima and I can be present when I'm working with her. And those are all my clients. Did that answer your question? It's not that black and white.
Yes, thank you very much.
Thank you. And only share what you feel comfortable with. Like if you're still having trauma and unresolved issues, don't share because then you can deregulate your clients. This is a fascinating thing that I've been learning with brain spotting. Anybody know people who get married and they start saying they start to look alike? You know, my partner and I have come out of the bedroom and, you know, I'm wearing jeans and a back turtleneck and he comes out an hour and a half later, hasn't even seen me and he comes out with jeans. I'm like, you go take those jeans off or that turtleneck because I got dressed first. Our brains actually, the people you surround yourself with. So if you have negativity, if you have power hungry people, if you have controlling people, our brain synapses have shown that we can actually start to grow neurons that start to match each other. How fascinating is that? So on that note, I'm going to put my professor's hat for 3 seconds. I'm a big, big believer. Your career is different than your job. And your career will only expand if you surround yourself with amazing supervisors, leaders. I don't know what you guys call them in the medical world, but leaders. Dr. Davis, you did mention a word and it's not coming to me. Your heads of the department, we call them deans in the college world. Your career and your development will only continue to scaffold if you surround yourself with a great, amazing mentors, supervisors, deans, or your terminology that medical world use. And when Dr. Davis was brave enough to share with all of you that she still gets butterflies in her belly when she has to make that call, that is a mentor. That is someone you want to surround yourself with because that person is able to be aware of themselves, which then can support you. Listen, all education is we learn to crawl, then we learn to walk, and then we learn to run. That's what you're doing with your scaffolding of your education. So if you really want to run and go for the skies and go for your dreams, surround yourself and take the initiative to create networking systems and mentoring systems that's going to grow your wings and the sky's the limit for you. I agree that to the extent that we can surround ourselves with good people is protective. Yeah, Nikki, I need people around me that I can go, I didn't know what to do with that client and I'm really scared, but I'm going to learn about it. And I'm going to tell the client that I'm scared and we're going to work together and figure it out how to find them housing. Yeah, the more real we are, the more human, and I'm passing a little bit of judgment, but there's some doctors that still have that traditional, I'm the doctor, you're the patient. I've let that go a long time ago. I very rarely my clients will even call me Dr. Ventrella. I always say, just don't call me late for dinner. You know, when you work with jails and you work with prostitutes and you're working with pimps and you're working with kids who haven't eaten for 3 days. Yeah, I always said to my clients, you have to call me doctor for 1 day after I got my PhD. And my kids called me doc for 1 day. Now I say, just don't call me late for dinner. because that implies someone cooked dinner for me and I'm a happy, happy person.
Thank you so much, Dr. Ventrella, for joining us today. Such a provocative topic and such great questions in the chat that I'm sure we could continue on and, you know, really learn and dig in from each other and from your expertise. So thank you so much. I am going to sort of perhaps bring us to a wrap up, and we'll have Lisa say thank you and everything, recognizing that we've got another amazing speaker on board shortly who's going to teach us about palliative care. I don't know if Erin is here. That's Dr. Awesome. Gallagher. So Lisa, I'll let you do your thank you, and then perhaps what we can do with Dr. Gallagher's permission, if she's here, is allow a 5-minute stretch break so you don't get blood clots, because that's important.
And open up your cortex. Go open up your cortex because you're going to learn a whole new other things. Thank you. Blessings. If anybody has any questions, comments, you can email me at mary.ventrella123@gmail.com, or just call me. You can look me up. But please, blessings. You are doing important work, and I want to thank you, your medical teams, nurses, your whole departments. I know this is not an easy time, and we are grateful for everything you've done to make our community safe. Thank you, thank you, thank you. And again, thank you, Halima. Thank you. Blessings to everyone. Bye. Thank you again, Miss David, Lena, Lisa. Thank you, thank you, thank you.
Thank you, Mary.
Okay, so Dr. Gallagher is okay with us taking a quick 5-minute break, so we'll come back at 9:52.
Let's say 9:55. That way people are back. But Dr. Gallagher is going to start talking at 9:55. So be back by 9:55. Shake, stop blood clots, stand up, jump around.
Okay, so we'll get started, everyone. So I have a quick presenter introduction. So Dr. Erin Gallagher is a graduate of McMaster University's Family Medicine Residency Program in 2015, PGY3 Enhanced Skills Training in Palliative Care Program in 2016, and Master of Public Health Program in 2018. In 2017, she completed her clinical scholar training through McMaster Family Practice, followed by starting her own general practice in 2017 at Stone Church Family Health Center, where she trained as a resident. Academic interests include a palliative approach to care and public health palliative care, medical education, and leadership development. Clinically, Dr. Gallagher divides her time between providing comprehensive family medicine care to her patients and working as a palliative care consultant for McMaster's Hamilton teaching sites, Hamilton Health Sciences hospitals, and the community palliative care outreach team. So please welcome Dr. Gallagher to her presentation.
Thanks, Lisa. It's been so nice. I've had my attached residents introducing me from my Block 7 sessions. So it's great to be with you all today. I am disappointed, like I'm sure many of you are, that we are not in person, particularly for the nature of our content today. But I have done everything that I can to try and make this as useful, practical, and interactive as possible. So I do hope that you find it engaging. And I just want you to know that, as usual, when we do our LEAP modules, which is what this is, there's 3 modules that we're doing today combined. It is meant to be a safe space to have discussions around patients who are benefiting from a palliative approach and some of our own experiences. Please feel free at any time to unmute yourself or shoot a comment into the chat box. And we'll be using Menti again in a bit of a different way, in that you guys will break off for some small group sessions. And in doing so, have some practice about having some of these conversations with patients with each other. And as things come up throughout your practice sessions, so if you have questions or comments, or you're not sure how to word something, I want you to use Menti during your practice, because I'll get those comments and can look to respond to them when we come back together as a large group. So I'll remind you of that a little bit later. Okay. So nothing to disclose for today's presentation, and our first module that we'll start with is being aware. And these are our learning objectives. So with respect to our patients, upon completing this module, you should be able to describe how past experiences, attitudes, beliefs, values, fears, and biases can shape your care of these patients. Describe the importance of self-awareness when providing palliative and end-of-life care. And I think this bridges from what it seems really nicely from the lecture that you guys just had, the importance of introspection, knowing where we're at, and how our past experiences have influenced us when we walk into a room and look after a patient. And then perform a simple self-awareness exercise in your daily practice when providing palliative care. Our plan for this module is we're going to start actually with sharing some of our own stories. I have a small video to show you of some palliative care physicians who had some aha moments of their own, and you'll get an opportunity to see those. But then we're going to break off and you'll have an opportunity to share some of your own stories. And then we'll do some reflection on what it is that our patients want. As I said, we're going to use menti.com. This is the code. So if you guys want to bring this up on your computer or on your cell phone and just sort of keep it there, because we'll refer back to it throughout the various sections of this module. So the first part is sharing our stories, and I'm going to play this video. Hopefully you guys can hear it and see it okay. Just type into the chat function if you're not able to.
My personal experience was as a family physician in rural Manitoba in 1993. And I was in my office, and on one particular day, a young man came into my office with his wife. He was in his mid-40s. And it was the first time I'd seen him in my practice. And he sat down in front of me, looked very uncomfortable, and said to me that he couldn't live life like this anymore. He was living in severe, severe pain because he had metastatic colon cancer. And I vividly remember feeling extremely uncomfortable with the situation. And looking back, my discomfort was because I'd never received any education in the area. And I asked him what he was on for pain, and he said he was on morphine and he was on very small doses. But I knew no better, so I said to him, I'm sorry, I can't increase your morphine because you'll become addicted. And I remember him looking at me, getting up, and he began to cry, and he said to me, I hope one day, as physicians, you can better look after us. And he walked out of the office.
I had a young man who was 28 who I found as cancer, and it was a very malignant cancer, and he was absorbed by the cancer system. At that time, you know, you referred it to the oncologist, and then you never heard about the patient ever again. Well, I didn't hear about the patient until I was in my office, and I got an urgent call from his wife saying they just discharged him from hospital, and he looked terrible. And I saw him, and he was in absolute agony. And here was this vigorous young man who was bald, had lumps all over him, and he was in agony. And what I found out is they had fractured his neck in the ambulance ride home. And so for me, it was easy. I gave him a shot of morphine, although I wasn't sure how much to give him, sent him back to the hospital, and 6 weeks to the day later, I got another phone call from his wife saying they had discharged him again. And I found him in absolute agony in his home. He had had no pain control for 6 weeks. And I gave him a shot of morphine, and my hands were shaking as I was thinking about giving him another shot of morphine, because I was told morphine was dangerous, you know, and was I going to kill? And as I loaded up the syringe, he died in front of my eyes. Well, that was a Friday afternoon. I was absolutely decimated. And then on Monday, I went to the College of Family Physicians annual meeting, and the first speaker was Dr. Balfour Mount. And the first thing he said, and I'll remember it forever, is people do not have to die with pain. And it was like the heavens opened up. It was my epiphany.
Palliative care is not a place, it's a philosophy. It doesn't mean the wallpaper on the wall. It doesn't mean, you know, that special room with the flowers and that. But it's an attitude, it's an approach to care. It's a philosophy of care, and it can be done everywhere.
Okay, so hopefully those messages were not big surprises to any of you. And we're going to take a moment now to do some personal reflection. And when we break off into groups, it's going to be groups of 5. And I just want you to know that this is the same group that you're going to break off with for the rest of our couple of hours today. I want you to think back to an experience that you've had with a person facing a life-limiting illness or a death. And this can be a patient, it could be a family member or a friend, or it could be somebody that you were just having an observership with, not necessarily your own patient. And I want you to share it with the group if you feel comfortable to do so, because obviously these conversations can evoke a number of different emotions. And if it's just not the time or space for you to do this, then please feel free to pass. But if you are feeling comfortable, I want you to reflect on how that experience made you feel. And I want you to pay attention to those emotions and keep them in your memory for later. I also want you to think about how you think the other person or people in your story felt. And then why you think it made you feel the way that it did and how it affected you at the time. And if in fact this story has influenced your ability to look after patients from that time on. So have you had any aha moments that have helped you grow or shape as a practitioner? So Lena, if you don't mind breaking everybody off, and we'll take a good 15 minutes or so for you guys to share some stories with each other, and then we'll come back as a large group. Okay, great. So thank you everybody who was able to share their story. And I'll ask you to refer to Menti again. So you'll see the code 99199063. And if you wouldn't mind typing in what kind of emotions came up while you guys were sharing your stories, both for yourselves and for the other people involved. Sadness, conflicted, grateful, mixed for sure, regret, comfort, discomfort, hopeless, relief from sharing, honored, privileged, tension, frustration, wanting to comfort, conflicting goals within families, complex. I don't want to be one of those doctors in the video. Emotional wall. These are great. And if you wouldn't mind adding now, you know, what was it behind these emotions, do you think? What was it about the scenario or about yourself or about other people that led to these emotions? Throw that into the Menti if you can. So for somebody who brought up memories from medical school, I haven't thought about in a long time, right? And that's so important, right? Is reflecting on these things, because if we don't learn from them. And we often reflect on the bad scenarios, right? We reflect on the things that went wrong. And we very infrequently reflect on the situations that went right and that were really good, so we can bring those lessons forward with us too. And these things can happen on a subconscious, but also a conscious level. And sharing our stories is a way of bringing things to the forefront so we can learn from them. So thank you guys for sharing some of these things. I really appreciate it. And I hope it was a good opportunity, although a brief one, for you to be able to share some of these things with your colleagues, because we all have stories to share and stories to reflect on and grow from. So I'm going to go back to the presentation. And just point out that, you know, our experiences, as I said, can be negative and positive. And negative experiences can result in things that I'm sure we've all seen before: avoidance, inappropriate treatment, over-treatment. This slide always makes me think of our young patients with cancer, and unfortunately when it's terminal. And, you know, we get our notes from oncology, or we see our patient in the room and they're on their, you know, 407th line of chemotherapy, because we all have these ideas, beliefs, and, you know, perceptions around young people, and the fact that, you know, they don't die young. And so we are perhaps more aggressive and, you know, causing more harm than benefit, and not having the important conversations. So I always think about those patients when I see this slide. But then there are positive experiences that make us more empathetic, engaged, responsible, help us to make more of a difference in our patients' lives, and help them select more appropriate treatment options. So why is it important to be self-aware? I mean, we certainly discussed this already in the previous slides, but I think the most important thing that I've seen in my experience is a lack of self-awareness can result in us missing really important things. You know, I can think of times where I have given in my family medicine setting a little bit more energy to an appointment. Maybe I was open enough to reading the room a little bit more and asking the right questions, and having somebody booked for a completely different reason, you know, admitting to me or opening up to me that they were in fact suicidal. Right? You think about scenarios like that, and maybe you've been lucky enough to have a situation like that, but it makes you think about the times where maybe you've missed things because you haven't been as aware about what's going on inside yourself, and thus what's happening in the room. And we need to be able to do that for our one-on-one encounters. Every time we walk into a room, check ourselves, figure out where we're at, any of the emotions or biases that we're bringing in. But we also need to do it on a grander level. If you have been a part of the lectures that I've given through LEAP on some of the important conversations that we have when giving a palliative approach to our patients, I always say that, you know, we need to reflect on our own values and the things that are important to us. We need to reflect on our own fears and things that scare the heck out of us before we can actually think about having these conversations with our patients. And it's not necessarily about disclosing those things to our patients as much as it is about being able to go through the process of thinking about these, questioning these, so we can guide our patients through it. These are some suggested steps to self-awareness when we're having our patient encounters. So we've talked about becoming aware of our own feelings. We've also talked about imagining what other people feel and why they might feel that way. You know, we have lots of encounters that we label as difficult patients in our career, and often those patients are just scared. Right? And if you can take a step back and realize the emotion that's driving the behavior and the reason behind that emotion, it can help us see things from a greater lens. We need to look for patterns of responses in ourselves and others and try to understand and learn from them. And when that fails, we can do what's called bracketing. And this is acknowledging your own biases, assumptions, attitudes, beliefs, and values, and intentionally setting them aside during a patient interaction. So that's something you can try when the acknowledgement of your own feelings and biases or the other person's is just not getting you where you need to go. Another strategy is just reminding ourselves of what our patients want. So I'm going to play another video and we're going to talk about the importance of really just going back to basics and reminding ourselves about those key things that we can tune into when things are getting difficult.
The following dramatization presents a reflective scenario. It's not intended to model, but rather to promote critical reflection and group discussion about the importance of being centered in our work. As you watch the segment, consider the following questions. What is happening? What issues does it raise? What emotions come to your awareness? What implications does it have for how we practice?
When I was first starting out in nursing, I used to barge into a hospital room without really thinking about what was going on behind the door. But thankfully, there was one family, one person that actually made a difference for me. It happened one night when I was on a busy evening shift. I was behind in my rounds, so naturally I was in a hurry. Later that evening, when things had slowed down, a patient's daughter asked me if we could talk. I had a few minutes, so I said yes. That's when she told me she'd been taught that a person nearing the end of life needs to be in a space that is kept sacred, held sacred so that the ancestors will feel comfortable to come and help with the journey the loved one will make to the other side. Without quiet and stillness, her mother might not feel the presence of the ancestors and might wonder if she's been deserted. She asked me if I could carry out my duties more quietly and gently. Actually, I remember exactly what she said. Make a smaller ripple in the energy of the room. Now, no matter how busy I am, I always stop, look, and listen. I stop or just slow down a little before I enter a patient's room. As I enter the room, I take a moment to look at what is going on. I take the time to connect with the family and the patient's experience coming from a place of compassion. I do the best I can in the moment. Then I listen. I listen to what is going on in the moment. I listen to my own emotional state. Am I rushed? Stressed? Am I tired? And finally, I check my mind. What am I telling myself? What am I thinking? Then I calm myself and stay as quiet as I can inside.
As the scenario illustrates, it really doesn't take much more time to briefly stop and reflect on where we are at in the moment when engaging patients and families experiencing life-threatening and life-limiting illness. We are constantly challenged to balance the physical, psychological, social, spiritual, and practical needs of our patients and their associated expectations, needs, hopes, and fears. Being constantly mindful and considerate of a range of expectations, traditions, and a patient and family's specific experience with an illness can have a significant influence on preventing new issues from occurring. It can also contribute to a care setting that promotes personal and spiritual growth as well as important life closure tasks.
So having watched that clip, you can imagine how you might be more intentional in practicing self-awareness when you enter the room. And if you ever are feeling overwhelmed, which I imagine happens quite regularly, especially as you train as a resident, but it will happen throughout the entirety of your career, go back to these basic principles, right, about what our patients want. And we have lots of research telling us what our patients want, particularly nearing the end of their life. And that is adequate pain and symptom management, avoidance of inappropriate prolongation of dying, having a sense of control, which is another way that we can implement strategies as we enter the room. They want relief of being a burden to loved ones and others, and they want strengthened relationships with loved ones. Another study has talked about what matters most in end-of-life care, and these are things like having trust and confidence in your healthcare provider. So again, reflecting on how entering a room could look that way. Not being kept alive on life support when there's little hope for meaningful recovery, honest communication, to complete things and prepare for life's end, and not be a physical or emotional burden. And so I ask, how does knowing this and what's mattered most to a large number of, and it was Canadian patients in this study at the end of life, how does that help you in caring for patients and holding difficult discussions or in decision making, which is a big part of what we're talking about today? And, you know, it was a large population of Canadian patients that felt this way, but at the end of the day, this is not the same list for everybody. So certainly asking people what is important to them is a really great way to start a discussion. They may not know what you mean and want you to be more specific. Often when patients say that, I say, you know, I've kept it wide open on purpose. I really want you to start where it is most important to you, what comes up for you in this encounter about being most important. And giving them the opportunity to open up and speak in the beginning of an encounter can give you the time, energy, and space to, you know, settle down and check in with yourself and how you're doing again. Dignity and respect is obviously another crucial factor for people nearing end of life. And these are some of the questions that are asked when it comes to dignity and respect. And, you know, I will ask you guys, based on your various rotations and the places that you've been, whether it be in family medicine or on a really busy CTU ward, when you read these questions, what percentage of the time do you think patients would be able to say yes to these questions in those various settings? And is there a difference? And then what about the visitors and the family, right? Especially in the context of COVID. So to conclude, we often carry our past experiences and biases with us. Self-awareness is critical so we can learn from those experiences and grow as clinicians. And we need to be aware of what our patients want, particularly when we're overwhelmed, and we need a reminder of where our starting point is going to be. And that is the end of module 1. You will see there's not a lot of slides for these lectures because I'm hoping that with the rest of our session, most of our time can actually be spent on doing some practice of some crucial conversations with each other. So these are our learning objectives for the ACP module. No surprises here. We're just going to review some basic concepts, and then we're going to have some practice around how to have these conversations. So I bring this slide up first because it covers a lot of concepts that we've gone over before in LEAP content, but also that are going to be reinforced today. So this is a diagram of the various types of conversations and decisions that are made, particularly in a palliative approach to care. And you'll notice at the top of the diagram that throughout all of them, we are taking into consideration the patient's values, wishes, beliefs, and goals for their care. So we're talking about advanced care planning initially. And this is a conversation that ideally happens when people are well and not in crisis, and they can think about the things that are most important to them. And there's two key parts of advanced care planning, right? There is reflecting on those values, but also selecting somebody like a power of attorney to make decisions on your behalf based on what you would want them to be if for some reason you lost the capacity to make those decisions or to communicate them yourself. And so these are the types of conversations that then inform future decisions that are context dependent. So when we go into a goals of care discussion, this is, depending on the treatment that we do or don't choose, what is it that we're trying to attain from it? Is it life prolongation? Is it making me more comfortable, for example? Is it discovering what the actual cause of the symptom is? So those are various goals that can be had, and those inform whether somebody accepts or declines a treatment. So that is decision-making or consent. People often confuse do not resuscitate order with advanced care planning or goals of care discussions. It's actually consent or refusing consent to resuscitation or specific aspects of it. So it's important to know the difference between these conversations to make sure that you know which one you are trying to have in the moment, and to know also which ones have already happened, because they're all important and it's an iterative process and they all need to happen in and around the same time, with some being more important at crucial moments than others. Does anybody have any questions about that? Okay. This slide is just to remind you that it exists. So the government decides, if we lose capacity, who is going to make decisions for us. And this is the hierarchy that they use. If you as a patient are not comfortable with this hierarchy and you have somebody specific that you want to choose, you would select number 2, which is your power of attorney. And there are 2 different types, which you might know. There's one for health, and then there is one for property. So those are all of the things that you own in your estate. It can be the same person, but it doesn't have to be. When it comes to advanced care planning, there's a really good website, Speak Up Ontario. I've talked about this in previous lectures, but if you haven't had an opportunity to actually look through it before, I really suggest that you do so, because there are great resources, not only for us as practitioners to have these conversations with our patients, but also for the public, as well as other professionals, community organizations, agencies, programs, and researchers. So I'm going to play an example of one of the videos through Speak Up. Not sure why the sound's not working for this one. Let me know if you have any ideas.
There was a tech wizard on before who was talking about.
I've chosen my daughter Stacy to be my substitute decision maker. It's I
took it off.
We started talking about it for ourselves, but we also started talking about it because of my mom.
It's not something that's comfortable for some people to discuss.
I really wanted the kids to know what my wishes were, so that if something did happen to me, they wouldn't be conflicted. I've chosen my daughter Stacy to be my substitute decision maker. It's a level of trust that she would honor my wishes.
It's not really something that anybody wants to think about. Bringing it up, I find making it humorous is probably the best way to diffuse the emotional side of it.
I've had the conversation with all the kids and my parents and probably all of my close friends.
Anyone who will listen.
Yeah.
Yes, we have 3 sons. We've been thinking and talking about, well, maybe we need to have a conversation with all 3 of them and say, we've talked about it and we really think that Michael would be the better one to choose without offending the other 2, right?
Whichever son it is, we would consider that person as the spokesperson for all 3 and not the one who has to make any huge decisions, because we would have let all of them know what we would want.
Yeah.
I'm in a very loving family, and when I talk about end of life, it's almost an assumption that my parents are going to go before I am. A little bit like a silly thing that I would be talking about that, because I'm relatively young, done a lot of supportive end-of-life care. For me, I just see this big shift of when wishes are known versus when they're not.
It's giving comfort to people left behind that they don't have any regrets and they don't have any bad feelings about. I wonder if, Mom would have wanted that, or...
Why not help the people who are going to be there and be affected, and let them know and take all the guilt away from them?
What I've seen is a lot of weight being lifted off people's shoulders when it is addressed, when it is talked about.
I just sort of know in my heart that it's really important, not just for the person who's dying, but for all the people around them.
So I really like that video because it shares some key points, and sometimes you'll find it's a challenge to get people to talk about death and dying and end of life because it is uncomfortable to many. And if you can present it in a way that the people did in this video, right, it is a bit of a gift to be able to give people that may have to make a decision on your behalf the answers. So they're not having to, potentially regret a decision that they make down the road. In fact, the decisions should mostly be made prior to losing capacity. And if that's the case, then in an ideal world, the power of attorney is really just the communicator of those decisions. And it can be a huge benefit to loved ones that live on beyond the death of a patient. And so if you can frame it that way, sometimes it is enough of a motivation to get people to talk about these things. There's lots of research as to why advanced care planning is important. Lots of benefits, including what I've already spoken about, but also avoiding really aggressive measures, as well as the costs associated with unnecessary care provided at the end of life. I think one of the more important things that isn't necessarily highlighted on this slide is the fact that people who don't pursue advanced care planning and reflect on their values and what's important to them sometimes lose out on those things that are in fact important because they're caught up in futile treatments, for example, or paying attention to the things that they wouldn't have otherwise. And when you do this work long enough, you will hear time and time again that people wish that they knew that their time was limited and they would have spent it differently had they have been given the opportunity to really reflect on what was important. So we're going to move on to a case now. The case is, and I've left it vague on purpose because you guys are going to be responsible for filling in the details. You're going to start with Aisha, who is a 54-year-old woman who has lung cancer. And she was born in Canada. She's a grocery store cashier, and she lives at home with her husband and her 2 children. And I just want to reiterate that, advanced care planning can happen when people are well, but it can also happen when people are diagnosed with a significant illness. And so these are conversations that could even happen in a periodic health review. But with somebody like Aisha, we have 3 scenarios. We have a scenario, if you can imagine, being in the family physician office. You are the family doctor, and it's before diagnosis. So Aisha comes to you, say, with some concerning symptoms. Let's say she's been coughing and she's been losing a lot of weight. How would you have an advanced care planning discussion with her prior to a diagnosis, but being concerned about cancer? So that would be one of you. One of you would be the doctor in this scenario, and another one of you would play the patient. And you can refer to the slides that were sent to you prior to this lecture as a reminder. I would ask then that a second of you, or a second person, have an advanced care planning just after the diagnosis. So Aisha comes into the family physician's office to talk to one of you as the family doctor, and she's already aware of the diagnosis, but now it's time to do some advanced care planning. And then a third scenario, again, one of you is the doctor, one of you is the patient, and it's going to be late in the disease where she hasn't responded to treatment, and she, let's say, isn't a candidate for further therapy and is dying. How do you have advanced care planning discussions in those scenarios? And then for those of you who aren't involved in the direct scenario, I want you to take notes. I want you to be able to give some feedback to the people who are in the hot seats around maybe some of the language they used, or sharing some of the challenges that you have with these discussions too. So I would recommend giving about 5 minutes per scenario. Obviously, that's very short. This is not reflective of a real life situation. It is just an opportunity to practice and to totally epically fail, because it's a safe space. That's the expectation. It's just getting your feet wet in regards to these conversations. And then I'll remind you that there's the mentee, right? So I'm going to go to a new slide where it's, again, free text. And you guys can, as things come up, ask questions. How would you word this, Dr. Gallagher? Or I always struggle with this. Or, I find that these scenarios are particularly challenging. And when we come back as a large group, we'll debrief some of them, depending on how much we get. And if there are some really great questions after, maybe I can do a text document and send it to you guys after the fact. Okay. So Lena, we're going to break off this time and give 25 minutes for people. So it's 10:50, give or take now. We'd come back at 11:15 and debrief for a little bit. Okay?
Okay, I'm going to start the breakout session now.
Thanks. Looks like we're still missing some. It's only 86 people back here. Just wait a couple more minutes. Lena, are there still some people in breakout rooms? Or have we just lost a number of people?
Sorry, I don't know. I don't see any. I'm just looking right now. Everybody, I closed all the rooms, so.
Okay.
Yeah, I don't know what happened.
May have lost.
There's only, well, there's 88 now.
Yeah.
How many was there? I don't recall.
I think there was close to 100.
Yeah, okay. It's weird.
Okay, well, we can get started. Not sure. Chances are that was not nearly enough time, or felt like it wasn't nearly enough time. But thanks to those who were willing to jump in. You were really thrown into it there, and it's brave to certainly be the first ones to go. And the rest of you will have an opportunity to play a different role or play a role in the next module. So we've got some great questions and comments here. I am also, again, open to you guys unmuting yourself. One, to ask a question, but two, also, you might have some great tips and pointers related to these questions, right? It's not just me who has all the answers here. I'm sure some of you have been in situations that you could offer some advice to your colleagues who have posted some great questions here. One of the first questions that came up is, how do you approach advanced care planning conversations when people are resistant to having the conversation in the first place? And there's some overlap there with some of your other questions. I think the starting point for a question like this is reminding ourselves what conversation we are having, right? So people tend to get their backs up more around goals of care discussions and consent or decision-making discussions. Whereas what we are talking about right now with our patient is only advanced care planning. And if you remember the definition of that, it was very much just about getting to the values, beliefs, what's important to the patient. And so if you can remind yourself that that is what you're talking about, starting with clarifying that for the patient could be really important, right? And the nice thing about being a family doc is that I can always bring that up with patients and say, this is a conversation I actually have with many of my patients that don't have a serious illness, right? Because ideally we talk about these and I get to know people when they're feeling well and they're living their best, right? Because it's easy to talk about what's important to you. But at the end of the day, we never know what's going to happen to us. I could leave clinic today and I could be hit by a bus. Do I want to give my family and loved ones the favor of knowing what I would or wouldn't want and what's important to me? And one of the key questions that I ask people is, what abilities and what parts of your life are so crucial that you can't imagine living without them? Right? And it could be the way that your mind works. It could be the way that your body works. It could be about where you live and who's around you. It could be about the activities that you are able to do. So those are all, some of my pointers around how I would approach something with somebody who is resistant. And that speaks as well to the question around, cultural beliefs. We can always talk about what's important to people, right? That doesn't go against anybody's culture or religion, to my knowledge. Does anybody have any further questions related to that, or have any comments to offer of your own? Okay, do I bring up the POA of personal property and finance at the same time? Yeah, I do, because it's helpful to differentiate the two and the fact that they can be different people or they can be the same. And so for the power of attorney for health, which is what we're talking about, there is a package through the Attorney General's office that you can just Google. The link usually comes up as one of the first ones, and it goes over how you can designate a power of attorney and the witnesses that are required for the document. You don't need a lawyer or anything like that. How do you approach being hopeful but also realistic in a disease course that isn't quite clear yet, but likely terminal? If you guys are not aware yet of the podcast, it's called The Waiting Room Revolution, and it was created by two of our McMaster colleagues, Dr. Samantha Winemaker, who is a palliative care physician, and Cien Xiao, who is a palliative care researcher. And this podcast is incredible for patients and families that have are looking after or who have a chronic progressive life-limiting illness. But it is also amazing for us as clinicians. In the first 10 episodes, it talks about, or it gives us language to use with our patients. And this is one key example of what they refer to as walking two roads. So some of you might have heard it as, hoping for the best and preparing for the worst. Gentler terminology is hoping for the best and preparing for all outcomes, because there are a variety of outcomes and many variables that play into account, including somebody's suffering and complications and comorbidities and what might come up versus not come up throughout a disease course. And so talking about how we know that if we have these conversations up front with people, we actually have a lot of evidence to support this, that they tend to live longer and better lives, higher quality of life. And so if I can share that with a patient, often they are a little bit more hopeful about having the conversation because we know that we've prepared for all potential outcomes. Any questions or thoughts about that one? Yeah, so discussions are difficult in a clinical setting where you're scheduled for 15 to 30 minutes. Any tips for doing this efficiently? Yeah, so, in an ideal world, you're doing this in your family practice and you already know the patient really well, right? Not everybody, but many you will. For those that you don't, it is, sometimes you are the one who has diagnosed something concerning or that is very, very likely to be concerning. And you need to sell yourself to the patient. And I always do this. I always sell it as, there are 3 things that I can continue to do for you as your family doc. I can help you understand your illness, right? Often I hear my patients go to specialist appointments and, it was a whirlwind, lots of information and not a lot of time. So you can come back here and I can help explain it to you, because really illness understanding is step 1. The second thing I can do is help you manage any symptoms. And those can be physical symptoms like pain or nausea, but it can also be things like, having any psychological distress around what's going on or addressing any fears that you might have. And then the last thing I can do is help you plan for the future. And that's a process, right? We have yet to see where this is going to go. And as we do so, I need to know what's important to you. And I know a lot about you already. But, I might have some more specific questions, knowing what I know about your disease and some of the potential treatments. And if I don't know the answers, I can always find out. I can pick up the phone and I can call your oncologist or I can call your cardiologist and, find out some answers so we can, make those decisions together. So those are some of the ways that I would do it. Multiple follow-up visits are a guarantee, right? You absolutely need to have those. And I would encourage pre-booking them, because patients, as you heard one of the palliative care docs earlier in the lecture today said, they get caught up in the vortex of the specialist clinic or hospital and we lose them. until they can't get into the hospital anymore. And then we're picking up the pieces after the fact, way too late. So it's important to have pre-scheduled appointments that aren't a burden to the patient. You know, they don't need to be super frequent, but frequent enough that you can stay on top of things. What else is here? Yeah, so prognosis when you're not at end of life. So, you know, we talk about this in a number of the lectures that we have through LEAP. And it is in there's a lot of prognostic information in your Pallium Pocketbook, as well as the online modules through LEAP, which you guys have access to. You know, a starting point for a lot of people, if they want to know this information, right? Because it's really important to a lot of people, but not everybody. So you have to ask permission first. You know, can I speak frankly about this stuff? But often people will come right out and ask you. And you can start with population level data. So, you know, there's lots of information on Cancer Care Ontario's websites around prognosis, and again, pointing out that this is on a population level. So this is all done on studies of, you know, thousands of people, and there's a big spectrum or bell curve. And, you know, we talk about averages and we usually give ranges, but ranges are tough because when we do that, when we hit the beginning of the range, like 3 to 6 months, when people hit 3 months, they panic. And when they hit the 6th month, they kind of question what they've been told by anybody. And so we start with population data, but we also take into consideration people's comorbidities, right? So if they also have heart disease and COPD and poorly controlled diabetes, then chances are their prognosis won't be as long as the average statistic. And then from a clinical perspective, really it's about what's happening right in front of us. So you'll see a lot of testing done by our specialist colleagues, whether it be, you know, echoes or PFTs or CT, chest, abdomen, pelvis, to see what's happening with the cancer. And although these tests are informative, right, the most important thing around prognosis is how somebody is functioning right there in front of you. And it's not just that snapshot or time point that we see in that PPS scale. It's how that function changes over time. And we know that as people get closer to the end of their life, their rate in change of function, and those are the basic things that we do every day: get up out of bed, stay awake, eat a meal, keep it down, talk to, engage with our family, leave the house, toilet ourselves, all of those basic things. If they're changing on a week-to-week basis, then we think that prognosis is probably in the matter of weeks. If they're changing on a month-to-month basis, prognosis might be in the matter of months. It gets a lot easier when people are looking at days to hours of life because we see physical changes that are much easier to read. But really, giving people this information, and sometimes it's enough information for them to make their own conclusions, and they don't want you to go further. You know, they just want to know what they should look for. So guys, that's just a little bit of information that I can share with you today, some of the terminology that I would use. I hope it was helpful to go through some of those various scenarios, and you probably didn't get to all of them, but again, just reminding ourselves that advanced care planning is really about what's important to people. So even though that typically doesn't change from before a diagnosis to after a diagnosis to end of life, the context does change. And so people's goals and decisions around care often can change, even though the things that are generally important to them don't. And so some of you may have found that your conversation didn't change that much when you did the various scenarios. And if you did, I would ask you to question yourselves, were you having an advanced care planning conversation? Or were you having a goals of care conversation or a decision-making conversation? Because if you were having the latter, right, those can be the scarier conversations. And we can't have those latter conversations if we haven't had an advanced care planning conversation, right? The former makes the latter way easier. And if we already know our patients and we've stuck with them throughout the trajectory of the illness, it becomes that much easier. So I'm going to switch back to the presentation. I would like you guys to unmute yourselves if you have a question while I do this. I sent you guys the lecture already, so I'm not going to read through these, but these are some examples of how you can start some goals of care discussions. And I will remind you again that there is the Speak Up Ontario website or Speak Up Canada website that has a lot of really great resources for people starting to have these conversations. Your pocketbook is another great resource. So to conclude, advanced care planning is an essential part of good end-of-life care, and not just end-of-life care, but even for people that are well. You should promote it for your patients, your family, your friends, and also yourself. You know, how many of you have an advanced care plan, have thought about this in any detail, which will make you better at having it with your patients? And then several factors need to be considered when making care plans and treatment decisions. And that is it for module 2. So module 3 is about decision making. And again, we're going to break off for a fair bit of time here. I am just going to point you guys in the direction of what we refer to as decision-making framework. So we're going to review that today and some of the factors that influence decision-making and goals of care and care planning for patients. These are examples of ethical decision-making frameworks or algorithms. And you can see here that there are a number of different factors that we refer to at any time that we are helping patients make decisions, but particularly when there are challenges. So if a patient is conflicted, or if the family is conflicted, these are times that we can go back to these frameworks. This is one example, and it gives a number of different categories that would be considered. One of the cases that are reviewed in the Pallium curriculum is of a chief from a Northern Indigenous community who has end-stage renal disease. And the decision is in front of him as to whether or not he wants to do dialysis or not. And in his community, involving his family and loved ones in the decision-making process is key. But one of the biggest dilemmas and barriers for populations like this is that dialysis often isn't offered in their communities. So it means moving to another location and getting the care that's required to prolong life in a completely different city without loved ones around. And so just as one example, you can imagine how all of these variables would play into decision-making around that. This is another example of a decision-making grid that you guys can refer to when you go through the case that's going to be presented in the next slide. And what I am going to ask you guys to do is look again at Aisha. And you're going to have these decision-making grids in front of you when you are faced with the dilemma in the case. And think about some of these things and the questions that you might ask Aisha or ask the family members when trying to decide what to do when she's in the situation that she's in. And again, here we'll have one person being the patient, and we'll have two people actually. We'll say there are two powers of attorney. We'll say it's her two children. It could be anybody. But Aisha, unfortunately, is in a place where her disease has progressed significantly. Her PPS is 20%, so she's not really eating or drinking anymore. She's bedbound, spending most of her time sleeping, but she's had increased shortness of breath, cough, and fever for the last 2 days, and you're noticing some sounds of a probable pneumonia in her left lower lung. And of course, the questions here are, do we investigate or do we treat with antibiotics? And some of you may have some ideas about this right off the bat. But let's say, you have one family member who wants to treat no matter what. And Aisha is not able to speak for herself, or maybe she is in your scenario. You guys can mix it up however you like. But the other power of attorney or loved one feels as though it's time just to let mom go. Just keep her comfortable and doesn't think she would want to live longer in the state that she's in. There are a lot of different scenarios that we could have done here, like stopping aggressive diabetes management for somebody who is nearing end of life, discontinuing an ICD device for somebody with end-stage heart failure, treating a urinary tract infection in end-stage dementia, or a patient who's had a massive stroke and is no longer to take nutrition in unless it is in an artificial way, right? So you are welcome to use this case. You can use any of the ones that I listed, or you can use your own case. But the goal here in our next 20 minutes together as you break out is to help the family with the goals of care and decision-making around how you proceed in this situation, and dealing with a little bit of conflict in the meantime, but considering all of those variables in the decision-making frameworks. How would you ask questions related to what's important to mom, right? How much she suffered and what the illness experience has been like up until this time. Does she actually want to prolong her life and not be able to, play with her grandchildren anymore, or even realize that they're in the room, for example? So refer to the frameworks, think about some of the questions that you gathered from the last time that we broke out. We'll take another 20. We're going to run over a little bit just because we ran over initially to be able to debrief after, but we'll take another 20 minutes here and let you guys try and practice this scenario. And then we'll come back and debrief. And like I said, I can send out a document answering any of your other questions that you guys post on Menti after this scenario at a later date. Okay, so 20 minutes. We'll come back at 12 and we'll do a quick debrief. If anybody has not been put into a breakout room, please let me know. Could you please? Okay, so it looks like mostly everybody is back at this point. Again, I hope that was an opportunity to at least get your feet wet and try out some of the language that you would use in a real patient scenario with some of the ones that you were offered. No comments or questions came through this time. I'll just leave an opportunity for anybody to post some comments or questions or scenarios. I'll leave the Menti open for a while so you can do that. Please feel free again to unmute your mic. If you have any questions, I'll give it just a minute to let anybody speak up. And then, I mean, this is really just a common sense slide, right? When decision making becomes challenging, use your colleagues. And, you know, we all have access one way or another to a specialized ethical team. If we need some help really applying these frameworks, if we're not able to come up with some consensus amongst the family and the medical team. And to conclude this module, obviously many factors need to be taken into consideration when we are helping our patients decide how they want to move forward through their illness. The frameworks can help, and we do have some resources in the community when things get really tough, including an ethics review. And I'll sneak back to the Menti just to make sure that nothing else has come up, and it doesn't look like it has. So thanks everybody for your participation today. I really appreciate it. I know it's been probably a really long morning. I'll stay on for a few minutes just in case any of you have any questions. And if not, I hope you enjoy the rest of your day.